Knee replacement is one of the most successful surgeries, we all know that, but at the same time we do have literature mentions that about 25% of patients are still not very satisfied. And the main complaint, even if they are painless, they say that the knee doesn't feel normal. Now, total knee replacement is not the only procedure we are offering our patients. There is a spectrum of procedures available, starting from patellofemoral, unicompartmental, bicompartmental, then cruciate retaining, bicruciate retaining. So all these things are there, and the main determinant for this is going to be alignment. So let's talk of unicompartmental. It's a great procedure provided we select the patient properly and implant absolutely accurately. If not, then there is going to be a big disaster. So unicompartmental is a good procedure, but to get the implant right, it's going to be a problem. And when we talk of the conventional instrument, there are a lot of hurdles for routine orthopedic surgeon. There is a huge impact on survivorship, which depends mainly on the variables, which are patient factors. The accuracy cannot be same even if you are doing in a very morbidly obese patient like shown in this picture. The instrumentations are different for all the different companies. So whether we are going to be dependent on that and our results should be depending on the jigs, they are going to be important, and most importantly surgeon factors are there. There are many variables during surgery also. We have to have the center of femur which has to be accurate. How many times we are really measuring what is the valgus angle? How many times we are really measuring what is actually the anterior bowing of the femur? We are taking all as a single the 3 degrees rotation. So we are generally not considering any of these factors when we are doing a conventional total knee replacement. So if we do the permutation and combination, the potential for error in a conventional replacement for getting a perfect mechanical alignment remains very high. Let's see this literature in which this article, there are drawbacks in conventional surgery have been enumerated by Palsley, that is inconsistency of implant placement, inconsistency in bone removal, human errors, and requires a lot of instrumentation. And if we don't get it right, there will be a lot of disasters like this. So what experts say now? They always, even if they talk on jigs, they always believe in technology. And I definitely agree that they do believe, and there are situations when we have to take help of technology. If we are taking help of technology in every aspect of life, then definitely we should take help. If there is a system which helps us in alignment in all 3 planes, gives kinematic alignment, gives appropriate gaps, balances all degrees of movement, not only in 90 degrees flexion and extension, then that system is going to be definitely useful for our patients. So this second generation robotic, which I have been using for almost 3 years, it has got an image-free, no CT scan involved, handheld robotic instruments, intraoperative registration, mapping, planning, and various controls. When we launched it, there were a lot of questions. Is it just another navigation? Is it just a bone milling machine? Does it really improve alignment? Does it improve outcomes? Or just it's a marketing tool? So let's try to analyze and see that. When people ask, I think I remember a story told to me by my grandmother that we were not actually knowing what is robotics and we were commenting on that. So let's go on detail. So what advantages robot brings in is the precise real-time virtual bone mapping, virtual 3-dimensional image which is created by robot on the table. It works with the surgeon to create a real-time patient-specific surgical plan for desired bone coverage, limb alignment, deformity, correcting by adjusting the implant position in all 3 directions, which is very difficult in conventional instruments. More so, I found it very important in unicompartmental, where we can keep the tibia consistent and rotate the femur, adjust the femur in all 3 planes to get an absolutely correct alignment. Bone sculpturing, that is the burring, is absolutely extremely limited to stereotactic boundaries of the predicted haptic bone window. So let's see a small clip of surgery. This is the valgus knee, which is having almost 30 degrees of valgus angle. First of all, like any other case, we have to just take out osteophytes. Most important thing is that in kinematic alignment by robotic surgery, we have to do very limited soft tissue release and kinematically align the joint so that we can get absolutely perfect alignment also and good physiological proprioception after the surgery. So first step is to registration, and then as you can see, we map and we take the stress views also to assess the ligament tensions. So this is a varus valgus stress view. Next step is to map the femur and tibia. Just move the tracker on the femur and it creates a real-time image on the screen. You can rotate the image, see from all 3 directions how it is going to, do that. Because everybody, whenever we do the conventional surgery, everybody's, marking can be different. For example, there is literature, ample literature on white side line or a posterior condylar axis. There is a variation of 10 to 14 degrees. So like this, the bones are mapped in the second stage. Then you can see how the implant is going to fit and then adjust your implants accordingly in all 4 directions. So this screen gives you an opportunity to adjust not only the distal cut, the rotation of the femur, the depth of tibia cut, the varus valgus angle, and just correcting it kinematically and then go for burring. The burring also is done with a handheld instrument. So this gives a soft tissue assessment, because soft tissues are most important. So we can rotate the femur and then start burring. After this, you have an option of putting some jigs also, but I don't use jigs, and you can just use this burr. There are cylindrical burr, really works very fast. So like this, it is burred, and then you can get an absolute good alignment, and you can confirm the cuts also with standard jigs, this digital angel wing. This is now preparation of the tibia going on, and similarly, it is prepared. So that is a in brief surgical procedure. Let's see the literature. Justin Cobbs has mentioned that UK can be the first procedure of choice, and with robotics it is much more accurate. Another article which says that robotic UK is much more accurate, it improves alignment, less outliers are there. Another literature in which they says that it is accurate and reproducible. Most important is to accurate, reproducible plan, which is most important for the unicompartmental arthroplasty. In total knee replacement, this is an interesting study done by the same high volume surgeon, done on the cadavers, one side with robotic and one with a conventional instrument. A lot of improvement in the femoral alignment, rotational alignment is seen. Another article in which pain scores were 55% lower because the soft tissue dissection, soft tissue release is much more limited. One more article in which the TKR associated with the decreased pain improves early functional recovery than the jig-based total knee replacement. Other advantages are soft tissue protection. We all know that these are other articles. I'll just rush through that. It optimizes preparation also. So we say that TKR is a soft tissue surgery. My colleagues have said that MCL is mother of the knee. Then why play with that mother? You have to protect it. If you can kinematically align it and objectively measure the soft tissue release, what is adequate? If we get a knee which is 17 degrees varus, so everybody of us cannot spell out what is adequate medial release, what is adequate this thing. There is a lot of subjectivity. So this technology gives us a very good tool to measure objective soft tissue release, optimize the soft tissue release as mentioned in this article where they have scored it. So to conclude, as per this article, robotics here is to stay, at least in healthcare. It improves precision, bone preparation, optimizes ligament balancing, and not only in 0 and 90 degrees, but it is entire range of movement. That is a great advantage which can be answer for our mid-flexion instability. So is it navigation? Yes. It is bone milling machine? Yes. It is improving the alignment. It improves outcomes, at least in the short term. We will get the long-term results. Is it a marketing tool? It helps. So definitely it is like an all-rounder, I feel, and it is a good associate in the operation theater. So without change, there is no innovation, creativity or incentive for improvement. Those who initiate the change will have better opportunity to manage the change. That is going to be inevitable. Thank you very much.